Moving on, now we're going to switch to another herpes virus family member, a congenital CMV, or CMV and congenital form. And for that part of our presentation today, I'd like to introduce Dr. Megan Pesch. So she earned her MD at University of Michigan Medical School and simultaneously completed her master's in clinical research and went on to complete her residency in categorical pediatrics, followed by a fellowship in developmental and behavioral pediatrics at University of Michigan. She's certified by the American Board of Pediatrics in both general pediatrics and developmental and behavioral pediatrics, and she currently serves as assistant professor of pediatrics and director of the Congenital Cytomegalovirus Development Follow-Up Clinic at Michigan Medicine, University of Michigan. Her clinical work focuses on evaluating and treating children with developmental delays, autism spectrum disorders, and behavioral difficulties, including those with congenital CMV. She founded the Michigan CMV Project to increase awareness about CMV prevention, and she is currently the president-elect of the National CMV Foundation. Dr. Pesch has a personal connection to CMV inspired by her daughter, which we will hear about in her talk today. And she will provide an overview today for us of congenital CMV, epidemiology, newborn screening, and policy. Dr. Megan Pesch.
All right, hi everybody. This is great to be here. So we'll just jump right in. So as Dr. Tab said, I'll be talking about the epidemiology of congenital CMV, newborn screening, and also policy, which has been a really hot topic over the last 5 years, but gosh, over the last 6 months, wow, we've seen a lot of really exciting developments. So I'm just going to kind of take us back to the basics and just kind of remind everyone about CMV. So it's a very common herpes virus, which we just heard about in the last talk. When someone acquires it for the first time, they may experience some mild cold-like symptoms, but really maybe some lymphadenopathy, maybe a sore throat, but most people it's completely asymptomatic. So most U.S. Adults have been exposed by the time they're 40, and I won't say that's midlife, I'll say early on in life when they're 40. But in general, a CMV infection is harmless to most healthy people. But CMV is transmitted in bodily fluids and often in the saliva or urine of young children. So just to remind everybody, horizontal transmission of CMV would be, say, from a child to the child's mother, maybe through sharing a toothbrush, or the mom picks up the pacifier to clean it and, puts it in her mouth before giving it to the baby. Not that anyone would ever do that, that's gross. But as parents, we get a little gross with our own kids. And then vertical transmission, on the other hand, is when a woman has CMV circulating in her bloodstream, either from a primary infection, non-primary infection would be like with another strain of CMV later on, or even due to a reactivation of a latent infection. So that virus transmits through the placenta to the fetus, and then the fetus then has what we call a congenital CMV infection. So let's talk about risk of CMV. Toddlers who are in daycare are just little petri dishes for CMV. And so it's not surprising that congenital CMV is often seen in second babies. So some studies have shown that at any time, if you go and swab a bunch of kids in daycare, 70% of them will be shedding CMV in their saliva or urine at any given time. And this is because even after the child has the infection and the symptoms are resolved, they can shed CMV in their bodily fluids for months and months afterwards. So who is at risk then for contracting CMV? People who work with children. So often we'll hear about women when we're thinking about congenital CMV, people who work in daycares, but also mothers of young children. A lot of women that I have met are speech-language pathologists, occupational therapists, and the like. But what is really interesting, and I I'm happy to answer any questions about this, but I can't really go into this in detail. I could talk about CMV all day. But prenatal counseling about how to change one's behaviors to reduce the risk of CMV transmission or acquisition, that horizontal transmission during pregnancy, actually has been found to reduce the seroconversion from like IgG negative to positive, or similarly with IgM, and which is necessary then to reduce the number of congenital infections. Unfortunately, in this country, prenatal counseling about congenital CMV risk reduction practices is not recommended. It isn't that no one's mentioned it, it's recommended against by the American College of Obstetricians and Gynecologists. This is from an older practice bulletin, but the feminist in me their practice bulletin states, doing such behaviors such as not sharing food with one's children, giving perhaps like a cheek instead of the lips for a kiss, washing hands really well after diaper changes would be burdensome and impractical for women to implement during pregnancy, so it's not recommended. What is burdensome to do in pregnancy is to not drink so much caffeine. I cannot kiss my baby on the lips for a few months. So CMV in pregnancy. About a third of cases of a mother being infected with CMV during pregnancy will transmit to the fetus. And that differs kind of across the trimesters. Third trimesters infections have a much, much higher risk of vertical transmission than first trimester. This is the leading viral cause of intrauterine fetal demise or miscarriage and pregnancy loss. And I think that is something that kind of gets lost in all of this. And, we probably don't even know the half of it. So primary infections then, as we heard in our last talk, then become dormant or latent, and they occasionally reactivate. Usually people don't even know when CMV reactivates, but that reactivation can still pass vertically to the fetus. So people will talk about CMV immunity, and even though one may have CMV IgG in their circulating, one is never truly immune from CMV, kind of like the flu. Different strains all the time come about. So this is what blows my mind and will forever blow my mind. 30,000 babies in the US each year are born with congenital CMV. Why are we not hearing about this? And to put this in perspective, 1 in every 200 US infants will be born with congenital CMV. Now, during my pediatrics training, and I actually went back and looked at my board notes because I only remembered learning about kind of the most severe cases, and I learned that these babies were sick, and I'll kind of show you a picture in a bit about the typical presentation. And truly, when I went back and looked back at my notes about CMV, I had 2 slides in my entire training. And it's not uncommon amongst pediatricians to just not get this in their training, despite it being so common. So we have a lot of things to work on in the CMV world, which is unfortunate, although if anyone is interested to devoting their career to CMV diagnostics, the field is, there's lots to be done. So let's talk about mechanism of fetal injury, which I think for me is really helpful to then think about what clinical manifestations we see in the infant after birth. So there are 3 main mechanisms. Placental injury. So CMV causes a placental vasculopathy, which then can reduce blood flow to the fetus. And with any condition that affects the placenta, like truly the downstream effects on the fetus, you can see the fetus not growing appropriately, smaller head size, smaller overall baby. The CMV also, it's a neurotropic virus. It loves the fetal CNS and actually will replicate within the fetal CNS cells, particularly astrocytes, which when CMV kind of invades those cells, it disrupts that normal, typical progression of fetal brain development. So if a baby's CNS is infected early, all those distal processes of brain development are disrupted, and with cell replication, apoptosis, all of that. So then truly, parts of the brain do not get formed for early infections. For later infections, it's more of like a panencephalitis, but there can still be some disruption in myelination, a whole spectrum of disease. And then, of course, like the maternal immune response. Some immune response is good, but as we all know, a lot isn't always the best thing, especially for a developing fetus. So, when I look at kind of these mechanisms, and the more I've learned about the neuropathophysiology of CMV, it's just remarkable to me that any of these babies, do so well. And most of these babies do really well. So then thinking about that brain impact, let's take a step back, or take, I guess, a step forward, and talk about the neurodevelopmental outcomes. So anything that has to do with the brain, really, clinically can be a manifestation. So we see a lot of cerebral palsy. We see a lot of epilepsy. Motor planning disorders, so CMV loves the vasculature around the basal ganglia, which is the motor planning center of the brain. So gross motor planning, but as well as fine motor planning. A lot of these kids have apraxia of speech. Similarly, it can infect the, there can be a chorioretinitis, so we do see some visual impairment. And again, for any of these, there's really a spectrum depending on when in pregnancy the fetus was infected. Something we do see very, very common is hearing loss. So it's a sensory neural hearing loss, and I'll talk about that a little bit more in a couple of slides. But it is about 25% of all children born with congenital CMV will have hearing loss. And the hearing loss is so tricky because it's not always neonatal onset. Typically, it happens before age 5, but it can be progressive, it can be late onset. I have a patient who, she had known CMV and it affected one ear, and she truly woke up one morning with the hearing gone in her other ear. And for a lot of reasons, they decided not to do cochlear implants on the first. So she was a very cranky young lady for a few months until she got access to sound again. Similarly, vestibular disorders in that inner ear. And then autism. And I put a little star there because, when people talk about CMV and autism, there's a lot of hesitancy in kind of making that connection. So I do say it's an area of ongoing research. However, any condition that really affects the developing fetal brain can be associated with autism. Preterm birth, hypoxic encephalopathy, all sorts of things. But in my clinical population, I do see a really high prevalence of autism. And in children with CMV, I'd say about 40%. And what's unfortunate is because these kids have hearing loss, they often go later. They're diagnosed later, right? Because, well, of course he's not looking at me. He can't hear me. Or, there's kind of, it's a little bit more difficult to diagnose. But area of active inquiry. So let's talk about disease severity. We are thankfully starting to move away from this, but classically, and even still today, people put this complicated spectrum of disease into two buckets, as if like kids could just be put in one or the other. So there's what they call asymptomatic infection, which is 90% roughly of children, and then symptomatic is 10%. These are terrible misnomers because it has nothing to do with symptoms. These are the signs or the clinical presentation at birth. So asymptomatic, these babies look perfect. There's nothing that looks sick about them, but they may still have hearing loss. So many babies are born with asymptomatic CMV who have profound bilateral hearing loss. Symptomatic, these are the babies that are the sicker babies. They can have visible signs at birth, laboratory abnormalities like elevated liver enzymes. They can also have intracranial findings. And so on cranial imaging, you can see, well, a whole host of things: calcification, delayed myelination. It really depends. Polymicrogyri is a big one. And so the babies with symptomatic CMV, no surprise, tend to have poor neurodevelopmental outcomes. But it really isn't that simple, because in recent years, people, instead of just doing a cranial ultrasound, which is just through the soft spot, it's so adorable, they've been doing more and more brain MRIs of these asymptomatic babies and finding out that, yes, indeed, they do have white matter lesions. So this two buckets is not really panning out as I think one thought it might have about 50 years ago. So here's a little girl with severe symptomatic congenital CMV. Her name is Lucy. Her dad lives in Germany, and he said that Lucy said that I could use her picture today. And so you'll see she is very jaundiced. She has this petechial rash, which people would call it a blueberry muffin rash. That's kind of the key term we are taught in pediatrics to answer, like board questions. She has a small head size, and overall, she's a small girl. She also, you can't see in this picture, had an enlarged liver and spleen. So this is a baby with severe symptomatic CMV. And this is also a baby with severe symptomatic CMV. So this is my third daughter, Odessa, who was born pushing 8 pounds. She was not a small baby. She looked perfect at birth. There was no sign for us to really think of. She did fail her newborn hearing screen on both sides, but to be completely candid, she still had like gunk in her ear from birth, and she was all swollen. And so, my husband and I looked at her and we were like, well, of course this kid failed the hearing screen. And as a pediatrician, I had spent my whole career reassuring anxious moms that the newborn hearing screen does truly have a 90% false positive rate. So I was determined to go home and not be that anxious mom. And so we had what seemed typical 2.5 months, and then at 3 months, we brought her in for her repeat screen, and at that point, we found out that she had no hearing. It took us a long time to figure out what was going on with Odessa. We had a lot of genetic testing. When I asked her ENT, could this be CMV? And not that I had this clinical suspicion. It wasn't like this maternal premonition. I was just racking my brain of all the things I could remember that were associated with pediatric hearing loss. And he told me, no, she looks too good. This is probably genetic. Well, we ended up testing her urine. I had to go in and get the urine bag. It's like a little Ziploc bag that you stick on under the diaper. I had to figure out where to send it. When that came back positive, you can't tell a postnatal infection from a congenital infection that far out from birth. So then I had to figure out how to retrieve her dried blood spot, which was stored at the state, and get that sent to the University of Washington. And of course, it came back positive for CMV. But she should have received antiviral treatment within the first 31 days of life, which in an RCT has been associated with improved hearing and developmental outcomes long term, which is a really tough pill to swallow as a mother and a pediatrician who definitely knows too much. So this is Odessa right after she got her cochlear implants. And I used to end my talk here we've overcome, and she has cochlear implants and everything's great. But this is her now, and of course she's still the most beautiful little girl in the world, but things have been really hard. She has autism, she has global developmental delay, she didn't walk till 20 months. This kid did therapy 4 to 5 days a week for the first 2 years of her life. And then most recently, my family has moved, we say we're studying abroad in St. Louis so she can go to a special preschool for deaf children. So it's not okay, and the long-term outcomes can just really be devastating for children and families. So what are these long-term outcomes? It's a spectrum. Clinically, even before CMV, I did autism, so I love a spectrum. And 20% of children, 2025, will develop some sort of hearing loss by their 18th birthday. 60% of symptomatic babies, so the ones that look sick at birth, will have disabilities long term. Oh, and I should say, sorry, my daughter, we found out that she had severe symptomatic CMV. She looked perfect at birth, as you can tell, but then after that urine was positive, we did a cranial ultrasound, and her brain just lit up with calcifications and cysts and just things that, as a parent, you never want to hear. So babies with the most severe type of this disease can truly look perfect. Circling back, I think it's actually really important to remember, though, that 75% of these kids will have typical outcomes, which is so important to emphasize for families, because if you Google it, it's really scary. And I've touched on this point, so I'll just skip ahead. So what is treatment for CMV? Folks will talk about antivirals. Valganciclovir or ganciclovir is what is used. And the RCT was really focused on those most severely affected children. And as I mentioned, it's a 6-month course of twice daily oral valganciclovir, which has been associated with improved developmental and hearing outcomes. The hearing doesn't get better, but maybe it doesn't get worse. But that's not it. That hasn't really been shown to necessarily be true. The data is mixed in the less severely affected babies. So some folks will say, well, why screen for CMV? You can't treat it. Well, there are a lot of other things you can do. So early intervention, and included in this is get the baby hearing aids if they have a hearing loss, make sure they are hooked in with the appropriate specialists, the therapist, the physical therapist, the speech therapist. My deaf daughter started speech therapy at 4 months old. It is amazing what these people can do. And, to gain support and to be ready for what comes. So you can also manage existing sequelae. So these babies are at higher risk for seizure disorders and things like that, as I mentioned. And so if a baby was to have a seizure, you would have a much higher threshold to, take this more seriously than, a typical baby without these risk factors. And then you monitor for those new sequelae. You monitor the vision. You, of course, monitor their hearing. And you don't just watch and wait when one of these kiddos has a language delay, refer. And then family support. I can't tell you how important it has been for me to know that that's what caused this for my daughter, and to work with other families and to really just feel connected. My in-laws moved to town, and we had an idea about what this journey was probably going to be like for our family. And I think, that itself is treatment. So why screen for CMV? Most of these babies have clinically inapparent infections. They look perfect. But congenital CMV needs to be diagnosed by 21 days of age. And for those of you who have kids, those first 3 weeks are so, they're just crazy for families. After 21 days of age is really the point where studies have shown that it's impossible to tell postnatal from a congenital infection. Postnatal exposure, even in breast milk or from a drooling sibling, hardly ever causes long-term impacts. So they're two completely different beasts and have two completely different implications. As I mentioned, antiviral medications need to be started early if a child does meet criteria, and then all of these babies are at risk for progressive or late onset hearing loss. But there are certainly some barriers. So the current commercially available testing for CMV, I should say like screening testing, is impractical. So at my institution right now, we only have a urine PCR. So imagine trying to put one of those little bags on a baby in the hospital and delaying discharge until they pee. Like, babies physiologically only urinate like once or twice in the first 24 hours of life. So you're just sitting there waiting for the baby to pee, and it's a real barrier. People don't want to do this. At my institution, the bagged urine is a send-out. So then you have these kids, discharged from the hospital. They go to wherever their PCP is, perhaps out of network, and we have to track them down if we have a positive result. Dried blood spots is another alternative, but even now with my patients, when I try to track down a dried blood spot, it takes 4 to 6 weeks for the parents to send the information, the specimen to be released, comes to us, we send it to the University of Washington. So at that point, the ship has sailed in terms of treatment. And dried blood spots are not very sensitive, unfortunately. This would be a great thing for everybody here to work on if you're in the industry. So the best commercial assay that's out there on the market right now is probably 70% sensitive. So, you've got more than a quarter of these kids that have congenital CMV, and we would never know, even with this best testing. There are some non-commercial assays that in research labs that can get up to 86% sensitive with a 2-primer approach, but still, you're going to miss a lot of these kids. That is why I'm actually very excited about the Diasorin Simplexa CMV. That's actually how I got connected with Dr. Tab. I cold called them one day and said, "Hey, I hear you might have something coming down the pipeline." Right now, the best saliva swab, which is a little cheek swab, you can only run 1 at a time. It's point of care. But the Diasorin product will be able to run about 8 in an hour. And in Europe, they have a 96 well, right? 96? Yeah. Which, when we think about universal screening, hopefully one day, that's really exciting to me. So something to look forward to. So in terms of screening approaches, what's really common, or becoming more common in the States, is something called hearing-targeted screening, which means you screen the babies who fail their newborn hearing screen for CMV, which sounds really good, but only about 7% of babies with CMV fail their newborn hearing screen. In fact, 43% of babies who will develop hearing loss by 8 weeks of age do not fail their newborn hearing screen. So you are missing a giant chunk of those babies that have directly actionable disease. And then there's routine or universal screening, which you just screen all the babies. But there's pluses and minuses to each. Hearing-targeted screening does miss most cases, but personally, I think it's better than nothing and a really good place to start. And universal, they passed some legislation earlier. It was signed earlier this year in Minnesota, which will be the first state to do universal congenital CMV screening. Hopefully, they're in the implementation planning phase, but hopefully to roll out early next year. But it's probably going to be a heck of a lot more challenging to implement. And I'm glad they're doing it before Michigan, so they can tell us all how to do it. But I think it is the gold standard to work towards. Like it was said earlier today in the larger talk, my my graphic design budget was pretty low. So here you can see I've highlighted in purple the states that have a congenital CMV screening law mandated. Some of these, actually it's been a hot last 6 months, so some of these are still in the planning phases and have not been actually implemented. But just last month, Florida signed a hearing targeted screening legislation, and so that's really exciting. Minnesota, of course, Illinois, Indiana, and then Utah was actually the very first state to do this back in 2013 because a state senator's granddaughter was born with congenital CMV, and it was diagnosed late. So that bill got passed really quickly. And since then, they've done hearing-targeted screening in Utah, which has been a big success. They've recently started doing expanded targeted screening, which means if a baby's born with severe jaundice or some of those petechial rashes or has a very small head size, they will also do the screening. So that's kind of newer, but I think it's really exciting. And I'm originally from Canada, so I get excited when Canadians do something before Americans, because my whole life I feel like I grew up in the shadow of the United States. We would get all the music 6 months later, the shows a year later. So in 2019, Ontario became the first province in Canada, but the first region in North America to do universal CMV screening, and they just added it onto their dried blood spot, or they did it on the dried blood spot just with the rest of their newborn screening. Initially, it was an opt-in, but it was so interesting. They explained it as a risk factor for hearing loss. So when posed, they also did some genetic testing for connexin 26. So they would ask the families, do you also want us to add this on and screen your baby for risk factors for hearing loss? And 97% of people said yes. So then it's now an opt-out. Their assay is okay. But again, better than nothing. They've been developing this infrastructure to date. Well, the data that was just published, which was probably about a year and a half old, 143 infants had been diagnosed, and 140 of them had developed hearing loss, which is crazy high. But they're following this cohort long term. In the fall, actually, let me just take a step back. So what is the hope for universal screening in the US? Well, states make their own decisions about what is on their newborn screening, but there is this national committee that makes so it's the Recommended Uniform Screening Panel, or the RUSP, and they make kind of the recommendations for what is kind of their gold standards, and many states do follow those screening guidelines. So the foundation submitted an application for congenital CMV in the fall, and it is working its way through. I'm thinking it's a 3 to 5 year process. These things take time. And we did recommend saliva and urine PCR as our preference for screening specimens. So we will see. I'm hopeful, but it's certainly going to be a long journey. And the mother in me just screen all the babies right now. But the scientist in me, I do really want to see this data, and so I think it is worth. Half of me thinks it's worth taking our time and considering this, and being very judicious as we move in this direction. So just wanted to share a little bit of information about the National CMV Foundation, which is the only foundation right now in the United States for congenital CMV. So our mission is to prevent pregnancy loss, childhood death, and disability due to congenital CMV. And here are a bunch of our families with their beautiful children. And so we do a lot of advocacy. We're really working on clinician kind of training and education. There is a very exciting vaccine that is in phase 3 trials right now that would be more of They are targeting women of childbearing age, kind of like an HPV vaccine, at least in the schedule, not in how it actually works. But so, working with folks to kind of try to figure out how we can really advance CMV prevention and then also treatment for these kids. I've got some great handouts on the website, so check it out if you're interested. And I will stop there. This is Odessa. We took her to this hands-on kid museum, and the first thing she does is put on a lab coat, gets an otoscope, and is checking the kangaroo's ears. I'm like, oh yeah, you go to a school with an in-house audiologist for sure. So there's my information, and I'm happy to take questions. Thank you.
Thank you very much, Megan. I'll kick us off once again. So dried blood spots confirmed your daughter's diagnosis, but as you mentioned, they suffer from poor sensitivity. So is there a role for them? How do you see them fitting in? You also mentioned that for the RUSP recommendations, you're going with saliva and urine. So any more comments about that?
Yeah, well, I think we will see. If babies are universally screened with saliva or urine, I think the need for dried blood spot, will decrease. But even kids who miss their newborn screening, might need to circle back. And right now, it's been so huge. We have patients who are, I have a 4-year-old girl, typically developing, whose teacher noticed she was sitting like this in class, and it turns out that she had unilateral hearing loss. Come to find out it's from CMV. So, if you can't collect that specimen in the first 3 weeks, the dried blood spots are really your only shot for a confirmatory diagnosis. Yeah. Hi.
Thank you so much, Dr. Pesch, for that talk. I have a quick question. I know legislation changes and depends on the states, right? Some pushes more than the others. Do you have some idea how can we push a little bit more, some universal guidelines? Is it studies? We need data? What were you thinking in that aspect?
I know. So I think we need some bigger scale statewide studies, and I think I heard some gossip that they might be rolling out something in North Carolina. So I think kind of bigger population-based studies. At the University of Minnesota, they've been funded from the CDC to do a universal screening study, and so they've screened close to 25,000 babies with urine, saliva, and dried blood spot. But I think the CDC even wants bigger numbers. The pushback that I hear, it would be very challenging to have a saliva specimen. It's different from the Guthrie card, right? I also hear a lot about people not wanting to worry parents should their child be one of the 75% that doesn't develop symptoms. But, I think in this age of 23andMe and all that, I think things have changed from that paternalistic point of view, although I think some of that does still persist. So more studies are always great, and advocacy. Follow us on social media. You can get our calls to call your senator or legislator. Thank you.
Thanks for your talk. I'm aware of this phase 3 clinical trial, and
yes.
I've had the opportunity to help bend some IVD tests to work with some of these other matrices. Mm-hmm. So I'd be happy to talk to you some more. Might be able to connect. I'm curious, what do you think about the OB procedure of screening cord blood?
Mm-hmm. Yeah, it's OB what? I'm so sorry, I missed that. OB.
Screening cord blood at birth.
Oh yeah, I love that. I know that in Japan they do quite a bit of their studies have been on cord blood or, interestingly, dried umbilical stumps. CMV is a very hardy virus. In Michigan, we can go back to samples 30 years old on the dried blood spot, and it's still there. And let me tell you, 30 years ago, those things were in a hot room, in a box. It was not perfectly stored. So I love cord blood. I think that's great, and I'm pausing now. I'm not sure about the sensitivity because serum PCR hasn't been validated in newborns, but I think it's a great opportunity, especially, I don't know if anyone's ever tried like commercially banked cord blood to go back and test that. I don't know if anyone would let us use their precious specimens, but yeah, I think there are many types of specimens that could be used. Yeah. Hi.
Thank you for that great talk. Dried blood spots seem like the natural sample because we're collecting it, but unfortunately, the data suggests that there's not a lot of virus in the blood to begin with.
Yeah.
So even though at my own center we've driven down the analytical sensitivity of dried blood spots, it's really not the best sample. So
Yeah.
Hopefully you're advocating for saliva because at our center we screen with saliva and recognize that they're all false positives and then back it up with urine. So
That's exactly what we're proposing. Yeah, exactly. We want to go for the best test, and then we'll see where we land with the RUSP. Yeah.
So thank you for bringing awareness here today. My question is about screening of the pregnant women. So are there mandates, or there will be mandates to screen for antibodies for CMV so that seronegative mother can be educated and can be followed more closely in case of seroconversions with regular screenings?
Yeah, I think that makes a lot of sense if one can get antibody testing prior to pregnancy, because those honestly are pretty tricky to interpret. IgG, tells one that they have been exposed and had the virus in the past. IgM is tricky because you just really don't know if that was 6 weeks ago or 6 months ago, which have very different implications for pregnancies. So when there's an actual pregnancy on the line, it gets a little bit more dicey. And there's been some great, they do this routinely in Israel and parts of France in a clinical study. And at least the Israeli data tends to suggest that people, there are more terminations of pregnancy. But I'm always a proponent of more information, so I think we honestly need some better tests in pregnancy. There also are no treatments that are used in pregnancy to prevent the vertical transmission. There have been some nice studies, again in France and Israel, about using some antivirals with mixed results, so we need some more replication studies on that. But I think prior to pregnancy, and I guess the IgG also, one could have a positive IgG and still get another strain or still have a reactivation, which heck, there's nothing you can do about that. So I feel like education is just the bare minimum.
I was just reading last week about legislation, specifically proposed legislation that had failed in the U.S., specifically around California and Maine. And it looked as though Maine put together a committee to review why the proposed legislation failed. And I really dug into the committee findings, and one of the things that they cited was the cost associated with the urine and the saliva as opposed to the blood spot, and the significant cost to the hospital. And when talking to my team about it, we were wondering, is it a big cost difference, or is it a workflow issue within the hospital that maybe they're not wanting to change or can't change?
Totally, yeah. No, I think that's really great. Thank you for bringing that up. A lot of these bills have not had appropriations with them. Minnesota is really the only bill that has passed. It had $2 million of appropriations for startup. Otherwise, these bills are just getting passed, and it's like, well, good luck, Department of Public Health, cut something else. So, it's interesting. It depends on the data you look at. So the saliva swab that's on the market right now, the equipment, depends on which rep you talk to, is either free or around $4,000, and the cost billed to insurance, which of course is going to be a little different in different hospitals or with insurance, is around $43 for the saliva swab. urine PCR, I know at our hospital it costs $120, but that's a send out. I think if you did it in-house, it would be less. But I think it's a lot of this like infrastructure, right? Like collecting the saliva, and instead of right now, it's just all the dried blood spot just goes somewhere central. And so I think, at least for my hospital, you know, it's kind of like somebody else's problem once we like get the dried blood spot, like, you're goodbye. You know, if you need follow-up, you go to a state center. And so it will take a lot of planning to do a saliva. But, you know, like, we've done newborn hearing screening. That is a heck of a lot more cumbersome than a saliva swab, and the follow-up for that. And I do think because CMV dovetails so nicely with the hearing loss, and in Utah, it's the early hearing detection and intervention folks that follow that positive CMV screen. So there may be some way that we can kind of overlap the two. But gosh, I wish there was an easier answer. It's messy, yeah. All right, thank you, everyone.